Now we're going to take a little bit of a history lesson and a theoretical dive into the causes of schizophrenia. So we're going to see these two things are totally linked, the history and the cause. The history is that back in the 50s, these drugs had been developed and were being developed, but nobody really knew how they worked. So there was a need for treatments for individuals who just couldn't function because of their mental illness. And there was this urgent need to develop drugs then that could potentially treat people. And it was honestly just like a total trial and error approach. They would take a drug that had been developed, try it on people with depression, people with bipolar disorder, people with anxiety disorders, and people with schizophrenia. And it was just a matter of like, well, let's see what works. They didn't know how these drugs affected the different neurotransmitter systems of the brain or the functioning of different parts of the brain. The technology just didn't exist at the time. And so what we've learned from that trial and error approach is that there were certain drugs that did seem to be able to treat the symptoms of schizophrenia, at least in some people. And what we're looking at here is a indication of the relationship between the dose, so the average clinical dose, and the amount necessary to block dopamine receptors. And look at this correlation. It is absolutely like amazing. None of your Psych 300 or 301 research projects are going to come up with a correlation like this, I bet. I mean, you just don't see this in the psychological literature. What we're looking at is that the dose needed to control the symptoms here on the x-axis is almost like 1-to-1, like a perfect correlation, 1.0 correlation almost, related to the dose necessary to block these dopamine receptors. So, what do we take from this? There's clearly a relationship between blocking dopamine receptors and treating the symptoms. And from that, then we get the dopamine hypothesis of schizophrenia, that there is clearly then some relationship between the dopamine system and schizophrenia, right? And so it came out of this just total trial and error approach. So some of the drugs here are older drugs like chlorpromazine. That's one of the older drugs. We're going to take a look at the role of dopamine in schizophrenia and some of the drug development that's occurred in this field. So let's take a look at the drugs used to treat schizophrenia. They are called antipsychotics. They help some people, but not everyone. So note that they don't help 30 to 40% of individuals with the condition. Now, a big distinction to draw is between the earlier first generation antipsychotic drugs. These are often called typical antipsychotics. The examples are chlorpromazine and haloperidol. So these are ones that are considered first generation. They are known for leading to difficulties with movement. So they interfere with the normal functioning of the movement system, and they lead to a couple of different types of symptoms. So one type of symptom is something called tardive dyskinesia. Tardive dyskinesia can take different forms, but it is a repetitive, certainly unwanted series of movements. It may involve the eyebrows, So sort of like kind of bring them up and down. It may involve the lips and the mouth, the tongue. It may involve the hands or even the feet and or the legs. So it can involve a number of different parts of the body. So let's take a look at this type of movement condition, and then we will contrast it with another type of movement impairment that these drugs unfortunately develop.
My name is Jeff. I live in Northeast Philadelphia. I was diagnosed with schizophrenia when I was 17 years old. I had a rough time growing up. There was a lot of difficult situations that I had to endure. Didn't have any friends at that time. Felt hopeless. But once I had my first breakdown, I was hospitalized then, right before I graduated high school. I stayed home basically that whole 1970s. That was a whole decade that was unproductive, and if I continued to do that, I would wake up one day, an old man, and not have felt like I accomplished anything. I was seeing a psychiatrist, and he encouraged me to enroll into a mental health program. The program was very big on building social skills, making friends, and being part of society as a whole. And that was important because that made me build up my self-confidence. Over the years, I was on a lot of antipsychotic medications until I tried one particular psychiatric medication that soon after I started taking it, I felt the best I did since I was a little boy. I had no self-consciousness being out in public on this medication. When my psychiatrist warned me that I would develop physical symptoms in several years in the future, I wasn't really concerned about it because I was doing so well. I didn't want to have the risk of giving that up. Several years later, I woke up one morning and I noticed that my cheeks were puffing in and out uncontrollably. And I was horrified when I saw my image in the mirror. And then the puffing in and out changed to grimacing, and I wasn't surprised that I was diagnosed with tardive dyskinesia, TD, because I knew grimacing was one of the symptoms, but I was surprised. I started to have other physical problems that I wasn't prepared for. TD has had a big impact on my life. My symptoms of TD are very visible, and as a result, people look at me differently.
And so these first generation antipsychotic drugs, again also called typical antipsychotics, are known for development of tardive dyskinesia. They also lead to Parkinson's-like symptoms. And so what we mean here are a tremor and a shuffling walk, shuffling gait, much as you would see in an individual with Parkinson's disease. These types of symptoms are coming about because the dopamine reduction is influencing the basal ganglia. And remember this whole idea of compensatory responses. And so if you have a drug, you're taking a drug that's consistently lowering dopamine levels in the brain's going to compensate. And these neural pathways then compensate in cases by increasing the sensitivity of these D2 dopamine receptors. So remember, dopamine has a variety of different receptors, subtypes, and the D2 is one of them, and that's the one that is particularly associated with these typical antipsychotic drugs, the first generation drugs. And so the development of these symptoms is often associated with a high level of blocking of these D2 receptors. Unfortunately, these symptoms are usually permanent, and so they persist even after the person changes medication or stops taking these medications.